I'm Ken Paris. I am a pediatric immunologist from the US. And I've been involved with Jacobson syndrome and both the European family group as well as the American family group for almost, I think, 10 years now. And my involvement began when we began screening newborn babies in the United States for immune deficiencies. And we realized that there were children being born with serious immune deficiencies who then were diagnosed in the first few weeks of life with Jacobson syndrome. And since then, we've realized that there can be immune system problems in patients with Jacobson syndrome that occur throughout their childhood and even young adulthood. And I've given a very similar talk at both this meeting and at the meeting in the United States. And so today, my talk about the immune system will be much shorter. But because of what's been happening with COVID-19 and the global pandemic over the last 2 years, I felt that this would be a good opportunity for the group to be able to ask an immunologist about what they should do for their children and families in regards to COVID-19. And I realized that this would be important for this group because Paul and I have received many emails from families about COVID infections in their Jacobson syndrome children. And much like Paul's talk, I do want you to ask questions. And if there are people online who have questions, to please ask them as well if they have questions. So I recognize many of the people in the audience today, but I do see new faces, and I'm sure there are also new faces online. So I have 3 objectives. The first will be to briefly review the features of immune deficiency in patients with Jacobson syndrome, just to refresh our memory. To go over some common questions and concerns that families have about COVID-19, and then to answer your questions. So let's get started. So we realized about 10 years ago that there may be problems in Jacobson syndrome patients in regards to their T cells. And T cells are the communication link of the immune system. These cells also directly kill bacteria and viruses. And therefore, they're probably quite important in preventing and controlling infection with COVID-19. B cells are another type of cell in our immune system, and the function of the B cells and their relatives are to make antibodies that defend against danger. And the danger can be bacteria and also viruses like COVID-19. They also talk to the T cells and give those T cells instructions of what to do. And if the B cells aren't working, we won't make antibodies. And in the last 2 years, we've all learned how important antibodies are in protecting everyone from COVID-19 infection. So antibodies are proteins that are the soldiers of the immune system, and they circulate in our bloodstream all the time. When our immune system makes antibodies, they're designed to destroy a very specific enemy. So a single type of antibody targets a single bacteria or a single virus. As I mentioned earlier today, we didn't realize how widespread the immune system problems were in Jacobson syndrome until more recently. And through discussions with families and with physicians around the world, we realized that patients with Jacobson syndrome suffer from chronic respiratory infections, ear infections, sinus infections, and lung infections. Many children have chronic diarrhea. In infancy, patients with Jacobson syndrome often have thrush or diaper rashes caused by fungus. And more recently, through meetings like this, we realized that many patients also have very difficult to treat warts. And I see some nodding in the audience today that their family members have this problem. So we realized that it's very important to test all children with Jacobson syndrome for problems with their immune system. Doing this test requires blood testing via a laboratory to measure antibody levels. We also need to measure the number or quantity of the T cells and B cells to make sure that they are present in the bloodstream. And we also need to make sure that the quality of the immune response is normal by using a special vaccine. And we often have to wait until children are a little bit older before we can complete the evaluation of their immune system. So at some point, we need to determine what is normal so we can reassure families that everything looks okay. And a normal evaluation means that your child has normal immunoglobulin levels. These are called IgG, IgA, and IgM. Normal also means that they respond well to vaccination or immunization. And we measure that by determining their levels of antibodies against diphtheria, tetanus, and a common bacteria called strep pneumoniae. And we also measure to make sure that they have normal numbers of T and B cells. We do that by measuring a white blood cell count, T and B cell counts on lymphocyte testing. And in the US and in most of the European countries, we measure what we call a normal newborn screening test at the time of birth to make sure they have normal T cells. So we realize that patients with Jacobson syndrome have lots of infections, and many patients fit into a category of immune deficiency that we call common variable immune deficiency. We also call this CVID for short. Patients with CVID have low antibody levels, and their response to vaccines or immunization is also low. Some patients have low T cells, and they all have recurrent infections of the ear, of the sinuses, and of the lungs. Many of them also have chronic gastrointestinal symptoms, such as diarrhea, abdominal pain, and infections. Patients with CVID have a more serious immune deficiency, but many patients who don't qualify for the diagnosis of CVID have hypogammaglobulinemia, which means just low antibody levels. Some patients might appear to have a normal response to vaccines or to infections with bacteria or viruses, but they still have recurrent infections, such as ear infections, sinus infections, and lung infections. On the other end of the spectrum are patients who have T-cell lymphopenia. These are patients who have a more severe form of immune deficiency, where their T-cell numbers are very low, or the function of the T-cell is low. These patients have infections with pneumonia, and we feel that they are also at risk for the infections of the skin with warts. Even in patients who have normal T-cell numbers, there may be abnormal functioning of those T-cells, which puts children at risk for infections. And this makes the diagnosis and management of patients with immune deficiency sometimes quite difficult, because the laboratory evaluation appears normal, but patients still have recurrent infections. And so there is a disconnect between what we see on paper and what we see in patients. And I always treat a patient before I treat a piece of paper with numbers on it. And so with Paul and Virgil from the Netherlands, we talked about how patients were being diagnosed with Jacobson syndrome, both before 2010 and afterward. And we decided that it was important to put a protocol for the diagnosis and management of patients with Jacobson syndrome in regards to the concern of immune deficiency and infections. So in summary, we feel that newborns should have T cells measured soon after birth or soon after diagnosis. And depending on where you live, this can be done with either newborn screening or with lymphocyte measurement in a laboratory with a blood test. At 4 to 6 months of age, we can measure antibody levels of IgG, IgA, and IgM. And at 12 months, we can measure antibody levels for the routine vaccinations, such as tetanus and diphtheria. After 2 years of age, we can then complete the evaluation of the immune system by measuring children's response to Pneumovax, which is a polysaccharide vaccine. And we measure how well the immune system makes antibodies after receiving that vaccine. There is a benefit to using Pneumovax in this age group because it not only helps us make a diagnosis of an immune deficiency, but in almost all patients who have normal or near normal immune systems, it can enhance that child's ability to fight off common causes for ear and sinus infections. So that vaccine that's given at the age of 2 can be both diagnostic, but also therapeutic. We also recommended that all children with Jacobson have a consultation with an immunologist in their country or their region, and to receive all the routine vaccinations as long as there is no known T-cell deficiency. We also recommended the use of a medication called Synagis in children who are less than 2 years of age, who either have recurrent respiratory infections or any documented immune system abnormality. And this recommendation came from Paul's experience with a young patient with Jacobson syndrome who unfortunately passed away from infection with the respiratory syncytial virus. And that probably could have been prevented had that patient received Synagis. The other thing we recommended was that all patients receive Pneumovax 23 for the reasons I mentioned in the last slide. We think it's important for patients to receive antibiotics early in the course of an infection rather than wait for several days, as we might do in patients who have normal immune systems. And we also strongly considered repeating the evaluation as children got older, especially if infections started to become a problem. We realized that the immune deficiency seen in Jacobson syndrome might be progressive over time or might not be recognized until children are older. And that's because we are still, unless we learn some more information later today, unsure of the exact gene or cause for the immune deficiency in Jacobson syndrome. In some children and young adults, we also recommended the use of prophylactic antibiotics, especially if patients had low T cells or a history of recurrent infections. And so, in summary, the management of the antibody deficiency in Jacobson syndrome patients includes immunization, antibiotics, and in patients who don't have normal antibody levels, antibody replacement with infusions called either IVIG or subcutaneous IG, so IVIG or SCIG. And so in 2020, so 2 years ago, when the global pandemic started, immunologists were obviously very concerned for their patients who had immune deficiencies. We were faced with a lot of unknowns in regards to coronavirus 19 and how our immune deficient patients might be affected by that infection. We didn't have effective treatments. We didn't have any immunization for COVID-19 at that point. And the products that we used for antibody replacement did not have antibodies against that virus. And so our patients who had immune deficiencies were at particular risk from infection. At first, it seemed like only older individuals were susceptible to severe disease with COVID-19. But without normal immunity, children like patients with Jacobson syndrome might also be at an increased risk for severe infection. Within the first probably year, I think Paul and I received many emails about the risks of COVID-19 in children with Jacobson syndrome. And those emails increased after the vaccines were developed because people realized that some individuals may not respond to the vaccine and be able to make those antibodies. And so as things have changed, we've had to answer a lot of questions. And the target keeps moving in regards to our recommendations. Even some of the medications that we would have recommended 4 months ago or 5 months ago in December 2021 are no longer being used to prevent or treat COVID-19 because the current virus strains are so different. So I'm going to present a few common questions and concerns that my patients have posed to me, and I'll try to keep the answers in the context of Jacobson syndrome, although my experience with preventing infection with COVID-19 in patients with immune deficiency is more common in other diseases that affect the immune system. I also want people to ask me questions, either here or online, because I think that there's a lot of value to being able to take the time, express your concerns, and then let some people with experience like Paul or myself give you our honest and sincere recommendations. So I think we need to understand how vaccines really work, especially considering that patients with Jacobson syndrome might not have normal T cells, normal B cells, or normal functioning of those different T or B cells. So vaccines are used to tell the immune system to make antibodies to prevent infections. And we think that these antibodies both prevent infection and also decrease the severity of the disease if an infection occurs. Some vaccines also are designed or have the ability to stimulate the T cells to directly fight off infection. And I think that that's very important for COVID-19 because control of the infection involves T cells. And that's why I immediately became concerned about patients with Jacobson syndrome or other immune deficiencies where the disease impacts the function of those T cells. So COVID-19 vaccines actually are a type of vaccine that can do both. They stimulate B cells to make antibodies, and they also stimulate T cells to fight off the virus directly. And so even if the immune system is not completely normal, the vaccines can, in some patients, help them make antibody, and in other patients, stimulate the T cells directly. So if a patient doesn't make antibodies, it doesn't mean that the vaccine is a failure. The vaccine may have stimulated some of the T cells to fight off infection. And so a child or an adult may still be partially protected even if we can't measure the antibodies against the virus. The other important thing to remember is that vaccines almost always need booster doses in order to maintain their effectiveness or protection. Requiring booster vaccines doesn't mean that the vaccine is a failure. And in fact, we've seen this for most vaccines. I'm not at all surprised that this is now requiring 3 or sometimes even 4 doses to maintain protection against infection. And the number of booster doses changes whether or not you have normal immunity or an immune deficiency. So another common question that we have received is what to do in regards to masking. And the use of masks and the recommendations has shifted so many times, and it will continue to shift as the prevalence of the virus goes up or down in the community. And it's important to realize that masks work best to prevent the spread of COVID-19 from the wearer of the mask to the people around them. And so the question is, if I wear a mask and the people around me are not wearing masks, am I still protected? And the answer is that the effectiveness of the mask depends upon the material that the mask is made from, as well as the fit of the mask around your face. And so the best protection is the use of a mask called an N95 mask, which is typically only used by healthcare workers because it requires special fitting and the use of very special materials that makes them expensive. You can purchase N95 masks, but they're very uncomfortable, and not many people wear them on a day-to-day basis. There is another form of a mask called a KN95 or KF95, which I believe in the EU is called an FFP2, which is the next best thing. So it has a very good seal, and you'll notice that it has a different shape than the surgical masks that are blue and with just little ear straps. The FFP2 and KN95s are made from polypropylene. And if you have a nice seal, they're very effective at protecting the wearer of the mask from infection from other people. And they're excellent at protecting other people if the wearer has COVID-19. Surgical masks that are well-fitting can be partially effective at protecting you from infection. But we all know that air gets in through the sides, and so they're best used at preventing infection to others, not necessarily protecting you from infection. When mask supplies were very low, there was a recommendation to use face coverings made of fabric. But now that we have masks available, many people are not wearing cloth face coverings because they're not as effective. Sometimes we use a cloth face covering over a surgical mask or a FFP2 to increase the efficacy of those masks. The other question that has been asked now is, do healthy people, such as family members or parents of patients with immune deficiency, need a fourth booster? And this question is coming up more and more because in the last several months, both in the United States and in the EU, there have been recommendations or approvals of a fourth booster dose in some age groups. So in the US at least, and in the EU for some patients or for some individuals, a fourth booster is approved for individuals over the age of 50, and that is 4 months after your last jab. There's no official recommendation about a fourth dose. It's only that it's approved for use. In the EU, a fourth booster dose is approved, but it varies depending upon the population and where you live. And here I say, what about patients with Jacobson syndrome or immune deficiency? We now have some recommendations about who requires a fourth booster dose in order to maintain protection from COVID-19. And I believe that many Jacobson syndrome patients probably should get a fourth dose. The official list includes patients who were treated for a malignancy or for cancer, patients who received an organ transplant or a bone marrow transplant, patients who are taking an immunosuppressant medication, such as chronic steroids, patients who have HIV or another form of primary immunodeficiency. And since we know that patients with Jacobson syndrome often have antibody problems or immunodeficiencies, I think it's important for everyone with Jacobson syndrome to receive a fourth booster dose to maintain protection against the virus. And I have one question in the audience that I do want to address. Cindy?
Those recommendations are for people who didn't get COVID or to prevent COVID?
Good question. So the recommendations for vaccination are independent of whether you've been infected with COVID-19. Meaning that even if you had the infection, the use of a booster dose can increase your protection from a future exposure. We've seen breakthrough infections after infection in normal individuals as well as patients with immunodeficiency. I think that patients who have, or individuals who have received the vaccine and who have maybe had the infection itself do have an increased level of protection, but as we know that that protection decreases over time. And so you're probably going to need another booster dose to maintain protection. But this is such a moving target as the viral strains shift and mutate, and as the amount of herd immunity and infection in communities changes, the need for booster doses may also change. I'm also going to talk a little bit about future vaccines, because things have changed so quickly. It is likely that the strategies we use to prevent infection in individuals is also going to change. I have another question. Camille?
Yes. What age do you consider the kids should have his first dose? Next question. Okay.
Next, it is coming up. So the question was, at what age do you consider using the booster vaccine? And the boost dose is defined based upon the age of the patient and also whether they have any evidence of immune deficiency. So one question is also, how effective is the vaccine in protecting young children, the ages of 5 to 11? So at least in the United States, the Pfizer vaccine is authorized in children 5 to 11 years old, and also in the EU. The question is, does that work in young children? And the answer is yes. The dose is different, though. The dose is a little bit less than what we give to adults. It's about 1/3 of the adult dose. 2 doses of the vaccine reduces the risk of Omicron infection in children between 5 and 11, but we admit that it's not as effective as it is in older children. And we have to think that the efficacy of the vaccines has also changed because the virus that it is protecting from has also changed from the original COVID-19 to the most latest strain called Omicron, which is much more infective than the original virus. But what we also know is that even when children were infected with the Omicron strain, the children who were vaccinated were significantly less ill than patients who were unvaccinated. So while it's effective, it's not as good as when it's used in older children. Yep, another question.
Can you give any advice on children under the age of 5?
Mm-hmm.
Because I know in the Netherlands at least there's no vaccine for the general population under 5.
Yeah. So the same is true in the United States, and there is work being done to see if it's necessary and also effective in the age group of essentially 2 to 5 years of age. We don't have an approved vaccine yet, although there are clinical trials ongoing about the use of the vaccine in that age group. It has been challenging to to get approval for those vaccines. It's a hot topic. So the next question is there a best vaccine? Because there are multiple brands, right? Different pharmaceutical companies have made different vaccines. Before I do that, I think there's one more question from Gesa.
Yeah, and the question is related to that question as well. So for the forced vaccination or for the younger children, is there like an official recommendation that we could hand out to the doctors to get the fourth vaccine or to get our younger children vaccinated?
Yep. So I have a slide that goes over a little bit of the recommendations for booster vaccination in different age groups. But I anticipate that those recommendations will also change. And that will be based upon how the vaccines work with new strains of the virus and what is happening in regards to the duration of protection after receiving those vaccines. This has all been a very difficult journey, even for the physicians, because we are often unable to give you accurate information because it's changing so quickly. So with so many different vaccine brands, people ask if there's a best vaccine. And the answer is that any vaccine is better than no vaccine. They all help prevent severe disease and reduce the risk of infection. And the benefit of one vaccine seems to be the downfall of the other when we compare the two, because there are no real head-to-head trials of each vaccine. So the Johnson & Johnson vaccine seemed actually to prevent Omicron a little bit better than the Pfizer or the Moderna vaccines. But initially it appeared that the Pfizer and Moderna vaccines seemed to be better at preventing the original strain of COVID-19. No matter which vaccine you received, remember that unvaccinated people are 2 to 3 times more likely to get infected than vaccinated people. And so if you're more likely to be infected, you're more likely to transmit that virus on to family members who potentially don't qualify for receiving any of the vaccines based on their age. Camille had a question.
Yes, we have a question from the chat from
Good.
Amy
Good.
in the UK. She's asking how she should do to get her fourth dose.
Mhm.
Should she ask the doctor? Because I don't know what are the recommendations in the UK at the moment.
I will have to look up the recommendations for fourth booster dose in the UK. I looked up US and EU, but now the UK is off on its own. They seceded. And so I'll have to look and see what the recommendations are. There may be some challenges with that, but based upon what I know about Jacobson syndrome patients and the living situation for some individuals, patients who live in group homes or in other facilities would qualify for a fourth booster dose in the EU, no matter what their age, as long as it's over the age of, I think, 5 or 12, depending. So a fourth booster dose is something to seriously consider. The next question is, what about new vaccines, which I feel is very likely depending on the emergence of new variants, such as Omicron. We've been lucky that the new variants seem to be less virulent than the original virus, but there is always a chance that a new variant could become more virulent or cause worse disease than the original virus. For now, it appears that the booster vaccines, which we know are safe, continue to be effective against Omicron and the new variants that are probably emerging around the world. But we can be reassured because I know that there are many other vaccines currently in development. And we now have the ability to shift and produce new vaccines a little bit quicker than we were 2 years ago when COVID-19 started. So what would be my recommendations for Jacobson syndrome patients if their immune system is normal? And I think first we need to recognize that they need to be fully immunized. Originally, I received questions about whether patients with immune deficiencies should even get the vaccines, because there was concern that there might be some danger in receiving vaccination. But we know that that is not the case. And in fact, it's even more important to receive the vaccine if you have any immunodeficiency. So getting fully immunized if your immune system is normal means 2 vaccine doses, or perhaps 3 in the age of 5 to 11. And for children and young adults older than 12, 3 vaccine doses. And to make sure that the entire family is also vaccinated. We have a question.
I need to address it for mother as well, so it will be instead, so we will get there. Luz had her second booster. So she didn't have her third booster yet because there was a period between her getting COVID and the second booster. What should be the intermediate between getting her fourth booster then?
So after infection with COVID,
Mm-hmm.
the current recommendation is 4 months
Mm-hmm.
after infection to get that fourth booster dose.
Okay, so just the normal recommendation
mhm.
still holds up for.
I think so, yeah.
Okay, check.
Yep. So what about if your child's immune system is not normal? So again, if you have any form of immune deficiency, low antibody levels, or other problems, you still need to get fully vaccinated. the vaccines continue to be safe, but they may not be as effective. So for children 5 to 11 years, it's 2 vaccine doses and 1 booster. For 12 years and older, it's 2 vaccine doses and then a 3rd and a 4th booster dose. I'm going to finish up talking a little bit about some other interventions that we can do for patients to protect them from infections. And even in patients who have very low or very poor antibody production, we recommend that you still receive the vaccine. And the reason is, even though you may not make antibodies, the vaccine is quite effective at stimulating your T cells to fight off the virus and reduce the severity of illness. The other option that we have in patients who really are significantly immune deficient is to use a monoclonal antibody called Evusheld, E-V-U-S-H-E-L-D. And this is essentially 2 injections that provide antibodies to protect from infection and to also reduce the severity of the illness if you are infected with COVID-19. So far, we feel that Evusheld will work for at least 6 months, but because it's a new medication, we're not sure exactly how long the efficacy will last. And we do know that it's quite effective against Omicron. It's approved both in the US and the EU for patients 12 years and older who weigh at least 40 kilograms. So unfortunately, it's not approved yet for younger children, but it is useful for some patients who are a little bit older. And then more importantly, what happens if a Jacobson syndrome or a patient with an immune deficiency does happen to get infected with Omicron? So our experience is that actually most patients recover or have mild to moderate illness. And we base that on our experience with other forms of immunodeficiency, not necessarily specifically Jacobson syndrome. We also know that antibodies are very important. And so since many Jacobson syndrome patients have some defect or problems making antibodies, we still worry a little bit about how COVID-19 might impact Jacobson syndrome patients. In older children who do happen to catch COVID-19 and seem to have some significant respiratory illness, there is an oral medication that's approved for use to treat the infection, and it's called Paxlovid, P-A-X-L-O-V-I-D. Also approved for patients who are 12 years old and over and who weigh 40 kilograms. It's not necessarily a new medication. It's actually antiviral medications that have been used in other illnesses. And it's an oral medication that we know is quite effective. And it has been shown to both reduce the severity of the disease and also decrease the number of days that you are symptomatic from infection. So I think the good news is that we're in a very different and better place than we were 2 years ago in regards to COVID-19 infections. We have effective vaccines, and more recently, we have the ability to treat infections with medications like I just mentioned. We know based upon the science and the studies that have been done, and also our experience, even in patients with immune deficiencies, that the vaccines and the treatments can significantly decrease both the risk and the severity of the infection. But unfortunately, what we also know is that we need to keep aware of new variants and the possible resistance that could develop in those new variants against the currently approved products. So, like I keep mentioning, there seems to be a moving target that we have to chase to keep people healthy. And so, if people have some more questions or concerns, or if there's new questions online in the chat, I'm happy to address them before we move on to the next speaker. Okay.
Got it. So we discussed about that 5 years old was the age limit to start the vaccination process. So Margot is 6, but now I wonder, because she got COVID 1 month ago, so how long before we enter the vaccination process?
Yeah, so the vaccination process after infection with COVID-19 can occur somewhere around 4 months after the infection. And that is because we feel that after a natural infection, you are protected for approximately 4 months with natural antibodies and immune cells to fight off further infections. We also know that after an infection with COVID-19, the vaccine actually seems to induce a more robust and long-lasting response to future exposures and infections. And you might be even better protected than if you had received the vaccine alone with boosters or just having had the infection. So the combination of infection plus vaccination seems to induce the strongest immune response. And I think most people who have had COVID on more than one occasion can say that their second infection may have been a little less severe because your immune system is already primed and ready to fight off the illness. But the other issue is that infections in those very young children do seem to be more mild compared to infections in older individuals and the elderly. But it's not 100% predictable as to who will have a mild or severe disease. And so when we think about this from a public health standpoint, where we want to protect the most number of children, we tend to recommend vaccination because it is a intervention that we can do for all children rather than take the risk of having people get ill with a mild disease versus the chance of having something more severe.
And linked to this question, when somebody got the COVID that once and react quite well, does it mean if he gets in the future another time, it will react the same way, or can be more severe or something like this?
So that's a very difficult question because the answer involves not just the patient or the individual's response to the infection, but also the virulence or the infectivity of the future variant that they may get. So patients who were infected with For example, Omicron in the last 3 months seemed to have more mild disease because the Omicron variant in general seemed to be, while it was more infective, it seemed to induce less severe disease. If a future variant causes more severe disease, I would be hesitant to say that the past infection would protect them. That's the only, we know so little about the natural history of COVID-19. And new variants may completely change our recommendations that we can give at this point. That's what's difficult.
You just told that the vaccine activates T cells.
Mhm.
In our case, Joyce has not enough T cells and they work very poorly. So how do you activate something that does not work?
It's a very good question. So that's where we're limited in making predictions, because each patient is an individual whose T cells may or may not work. And in those cases, the opportunities to use medications like Evusheld to guarantee the provision of antibodies that will fight off infection, or the use of medications like Paxlovid, are super important. Because it's a tool that we can keep in our pocket should a patient with a known immune deficiency catch COVID or have more symptoms when they do catch COVID.
The medicine you just called are not European registered yet, so that's a little bit of a problem for us then.
Evusheld, I think Evusheld is, and Paxlovid, I think, also. But these are new since the end of 2021. Sure. Any other questions? Okay, perfect. Well, thank you.
Okay, we have today two families online that would like to introduce themselves to all of you here in Pforzheim and online. So Marion, can you hear me? Can you open your microphone?
Yes.
And yeah, hi. Is it possible to have Marion on the main screen? Yeah, good.
Hi, everyone. So I'm going to introduce myself very quick. I'm 38. I'm a mother of 3 children living in Paris, France. And my second child, my daughter, is 6 years old, and she has 11q duplication, 76% duplication, actually. So she was first diagnosed with autism disorder, like my older son. But then they did the genetic test, so we discovered it was the chromosomal problem. And she has some health issues about digestion and also epilepsy. And she was non-verbal. Now she's talking. Now she's at school. And well, she's doing fine. She got COVID twice. She got no antibodies, and she got the Pfizer shot twice then, because in Paris, kids with genetic disorders were first to get the vaccine. So she got it like even when she was 5. So. Actually, these days are quite good. I'm a bit concerned about the epilepsy and the health issues, because since I'm working in the field of behavior analysis, I'm working with my children to improve their behavior. So this is not very concerning to me. I'm just learning about this disorder and trying to figure out how she can develop in the best way and be happy.
Thanks a lot. Just now that we have you online, don't forget to write to me if you would like maybe a private video session with either Ken or Paul to discuss about your daughter.
Yes.
I think we have another family online that would like to introduce themselves. Feinhauer, Johannes. Hi.
Hello together. Hi. My name is Johannes. I have 3 children, and our middle one, called Turit, she has the Jacobson syndrome, and she's 10 years old now. We found out that she has Jacobson syndrome when she was 4.5 years old, because her growth was a little bit reduced. And she's only a little bit affected, so it was not so obvious. And she's doing fine so far. She's more often ill than her brother and her sister. And she goes to the regular school, which is sometimes a bit difficult, but she's in the 4th grade now, and that's okay so far. She loves to play music. She plays the cello. That's something she really likes, and well, we hope it's going on good. So far it did, and we're interested, or we are happy to be now in the community and come in an exchange.
Thank you. We are very glad to have you with us today, and please continue to interact with us for the rest of the conference. Thanks a lot.
Thank you.
Okay.
Maybe specifically for the ones online. There you are. I'm actually by myself here because the youngest one is sleeping this afternoon. We're the family Albers. My youngest child, Anne-Sophie of 3, has Jacobson syndrome, which we found out because she was diagnosed with a heart problem during pregnancy already. And we found out that she had COVID about 3 weeks after birth, so relatively quickly. And we also have an elder daughter of 5 years old who has no Jacobson at all. So that's it.